Imagine holding, like, just a small, totally unassuming tube of cream.
Right, just your standard ointment tube.
Yeah, exactly. And if you use it exactly right, this stuff saves you from irreversible physical destruction and honestly, even cancer.
It's powerful stuff.
But if you use it wrong, it literally turns your skin into this spreading, fiery burn that can last for months. You are holding the ultimate medical paradox.
You really are. It's a profound physiological balancing act, honestly.
Right.
When the margin of error is this thin, I mean, the details matter immensely.
They really do. So welcome to the deep dive. We are looking at a pretty dense stack of incredibly detailed medical sources for you today.
Yeah, we've got some heavy hitters.
We really do. We've got comprehensive reports from the Medicines Adverse Reactions Committee, the official tapering guidelines from the British Association of Dermatologists, and a bunch of really eye-opening clinical trials.
A lot of data.
It is. But our mission today is to decode a very specific, highly debated medical phenomenon. We want to know, what exactly is the steroid rebound effect?
Which is also known as topical steroid withdrawal, or TSW.
Right. What is that effect in the management of vulvar lichen sclerosus, or VLS? Okay, let's unpack this. Because you already know VLS turns the body's immune system into, like, a relentless wrecking ball on delicate vulvar tissue.
It's devastating.
It is. So the real question is how the gold standard treatment actually intercepts that cascade. We're talking about ultra-potent topical corticosteroids, right? Things like clobetasol propionate.
Right. And to really understand the rebound, you have to understand the intervention at a cellular level first.
Okay, take us there.
So when a patient applies clobetasol, the steroid molecules actually penetrate the cell membrane, and they bind to very specific receptors, glucocorticoid receptors, right in the cytoplasm.
Okay, so they're inside the cell.
Exactly. And from there, this whole steroid receptor complex actually travels into the cell's nucleus, and it alters gene expression.
Wow, it goes right to the DNA.
It does.
Yeah.
It actively inhibits the transcription of DNA that produces inflammatory mediators.
Yeah.
Things like interleukin-1 and prostaglandins.
So it's basically pulling the plug on the inflammation.
Pretty much. It reaches into the control room of the immune cell and just flips the off switch on the whole inflammation factory.
But wait, I have to push back here for a second.
Sure.
Because I know you listening are probably well-versed in general pharmacology. And one of the cardinal rules we've always been taught is that, continuous use of ultra-potent steroids thins the skin.
Right, it causes atrophy.
Exactly. So if we are putting the heaviest hitters of the steroid world on some of the most delicate mucous membranes on the human body, aren't we just destroying the very tissue we're trying to save? I mean, aren't we trading one problem for another?
What's fascinating here is the unique pathology of VLS itself. You are completely right that in normal, healthy skin, long-term continuous use of clobetasol causes severe dermal atrophy.
It thins it out.
Yes. But the modified mucous membranes of the vulva are actually surprisingly resistant to steroid-induced thinning. And more importantly, we have to look at what the disease is actually doing.
Okay, what is it doing?
VLS causes this condition called hyperkeratosis, which is basically a massive thickening of the stratum corneum, the outermost layer of the skin.
Oh, I see. So you aren't applying this like nuclear level steroid to thin, healthy skin. You are applying it to an abnormally thickened barrier.
Precisely. The disease is constantly building up that thickness. So the steroid has to fight its way through that thickened armor just to stop the immune cells from destroying the structural integrity below.
Right.
When patients use these powerful steroids appropriately for VLS, biopsies don't actually show the typical skin atrophy you'd expect. The steroid isn't thinning normal skin. It is actively battling the disease-induced hyperkeratosis.
Just to restore it to normal. So it's a bit like sanding down a wooden door that's swollen shut from intense humidity.
Oh, that's a good way to put it.
Like if you took a power sander to a normal door, you'd ruin the wood. But in this case, you're just meticulously removing the abnormal swelling so the door fits the frame again, right? So it just functions properly.
That is an excellent analogy. The steroid is restoring the functional baseline.
But that sanding down process clearly has a dark side if you don't know when to stop.
It absolutely does.
Because while steroids are the hero of the VLS story, the data from the Medicines Adverse Reactions Committee highlights a pretty horrifying reality when things go wrong. Let's look at topical steroid withdrawal, or TSW.
Yeah, so TSW, which is sometimes called red skin syndrome or topical steroid addiction in the literature, is this rare but incredibly severe rebound reaction.
And what triggers it?
The crucial context here is that it occurs after the abrupt cessation of long-term continuous use of moderate to high-potency steroids.
And reading these clinical reports, I mean, the symptoms are staggering. If you are a patient experiencing this, it's not just a mild irritation.
No, not at all.
The defining symptom on the skin is intense, radiating burning pain, not an itch, but a severe burn. And it's accompanied by extreme redness, stinging, even oozing pustules. It's basically a localized inflammatory explosion.
It is absolute agony for the patient.
Yeah.
And it routinely causes severe non-cutaneous symptoms too.
Like what?
Well, the physical pain is so overwhelming that patients frequently suffer from deep insomnia, and that often leads to secondary depression.
But why does the tissue react so violently, like mechanically? What is actually happening in the body when you stop the steroid?
It really comes down to a massive physiological overcorrection. When you apply ultrapotent steroids daily for months on end, you are doing two main things.
Okay.
First, you are artificially suppressing the local immune response, which causes the body's own natural local anti-inflammatory mechanisms to downregulate. The local receptors basically go to sleep because the external drug is doing all the work for them.
They just atrophy from disuse.
Exactly. And second, topical steroids are potent vasoconstrictors.
Right. They shrink the blood vessels.
Yes, they tightly shrink the local blood vessels, which reduces redness and swelling.
Yeah.
But if you force those blood vessels to stay constricted continuously for, say, 6 months, the cells in the vessel walls adapt to that artificial pressure.
Oh, I see where this is going.
Right. When you suddenly take the steroid away, you don't just return to normal. You trigger a massive vasodilation rebound.
The blood just rushes back in.
Exactly. Blood rushes back into the local vessels at a totally unregulated rate, local nitric oxide levels spike, and you get a severe vascular crisis.
Mm-hmm.
And this is combined with an uninhibited inflammatory response because those local immune regulators are still asleep.
That makes total sense. It's like building a massive concrete dam to hold back a river. Because the dam is there, the town downstream completely stops maintaining its own flood walls. But if you just instantly detonate the dam, the water doesn't just return to its natural flow.
No, it floods everything.
Right. It causes a catastrophic flood that wipes out everything, even areas that were completely dry before the dam was built.
And that analogy maps perfectly onto a very specific, terrifying hallmark of TSW.
Here's where it gets really interesting. Looking at the regulatory data sheets, they emphasize that a TSW flare doesn't just mimic the original disease. The burning and redness actually spread beyond the initial treatment area.
Yes. This is called confluent erythema.
Confluent erythema.
Right. So if a patient was applying clobetasol to a specific 1-inch patch of the vulva, the withdrawal reaction, that vascular flood you just described, might cause fiery redness and burning that extends outward.
Into totally normal skin.
Exactly. Into surrounding, completely healthy skin that never even touched the steroid. The body's inflammatory and vascular response completely loses its spatial containment.
Which introduces what has to be the most agonizing diagnostic dilemma for both patients and clinicians. I mean, put yourself in the examination room for a second.
That's tough.
A patient with a history of VLS has been using their steroid. They stop, and 3 days later, their pelvic region is on fire.
As a doctor, how do you know if the underlying autoimmune wrecking ball of VLS is just coming back, or if you are looking at a full-blown topical steroid withdrawal?
It is a phenomenal clinical challenge, and frankly, the lack of universally agreed-upon diagnostic criteria makes it a highly debated topic in dermatology.
Because the treatments are totally opposite, right? Exactly. You have two conditions that cause severe vulvar distress, but the treatments are diametrically opposed.
It's the classic diagnostic nightmare. I sort of think of it like, is the house freezing because the heater broke down? Meaning the underlying disease is back and you need to restart the treatment.
Right.
Or is the house freezing because you abruptly smashed a window? Meaning you've triggered an acute withdrawal trauma, and giving more of the drug that caused the trauma will only deepen the addiction cycle.
Yes. If you misdiagnose a VLS flare as TSW, you withhold the very medication that prevents permanent scarring.
Which is terrible.
But if you misdiagnose TSW as a VLS flare, you prescribe more high-potency steroids, feeding the rebound cycle and setting the patient up for an even more devastating withdrawal down the line.
So how do the experts synthesize this? What are the clinical differentiators in the literature to tell the smashed window from the broken heater?
You really have to look closely at 3 pillars: sensation, physical architecture, and timeline.
Okay, let's start with sensation.
First, the sensation. A true flare-up of the underlying vulvar lichen sclerosus is overwhelmingly characterized by intense, maddening itching. A steroid rebound, conversely, is characterized primarily by prominent radiating burning.
So itch equals disease.
Yeah.
Burn equals rebound.
As a general rule, yes. Second, look at the tissue structure. If the VLS is flaring, you will start to see the return of those physical architectural changes.
The white plaques, right.
Exactly. The white plaques, the thickening of the skin, maybe the early stages of labial resorption or clitoral fusion. But in TSW, the primary visual is that bright, confluent erythema.
The spreading red rash.
Yes. Often with skin peeling or weeping, but usually without the immediate return of the white plaques.
Okay, and the third pillar, the timeline.
True TSW almost always follows a very specific history of prolonged, inappropriate, continuous daily use of moderate to high-potency steroids, usually for 6 months or more without a break.
6 months daily.
Right. And the massive burning flare typically begins within days to just a few weeks of abruptly stopping that inappropriate regimen. If a patient has been using the steroid correctly, just twice a week, and experiences a flare a month later, it is almost certainly the disease returning, not TSW.
This diagnostic confusion brings us to a massive kind of hidden variable in patient outcomes, and that's the psychological barrier.
Yes, steroid phobia.
Exactly. We see this phenomenon in the clinical trials referred to as steroid phobia. Because, I mean, imagine being a patient. You are diagnosed with a chronic, incurable autoimmune condition. You are handed a tube of clobetasol, and you open the informational packet.
And the side effects list is terrifying.
It really is. It lists skin thinning, adrenal suppression, and this terrifying, burning, topical steroid withdrawal syndrome.
It is completely understandable why a patient would read that and hesitate.
More than hesitate. Some patients read about TSW online, they see the harrowing photos on forums, and they understandably panic.
They do.
They either stop using their steroids way too early, or they refuse to start the treatment altogether out of fear that they will trigger this spreading fire.
And that fear, while deeply valid, paradoxically causes immense irreversible harm. If we connect this to the bigger picture, we have to look at the sobering reality of VLS based on decades of longitudinal studies.
Right, because it doesn't just go away.
No. As you noted, VLS is a chronic, lifelong condition. It cannot be cured. It can only be actively managed.
So if a patient driven by steroid phobia just walks away from the treatment protocol entirely, what does the data say actually happens?
The disease almost universally progresses, and the consequences of unchecked VLS are devastating. We aren't just talking about a return of the itch.
What are we talking about?
We are talking about irreversible architectural destruction. The labia minora can completely resorb, essentially disappearing.
Wow.
The clitoris can become entirely buried under thick scar tissue, permanently destroying sexual function and causing severe pain during urination or intercourse.
But the clinical data points to an even higher stake than functional loss, right? There is a cellular progression here.
Yes, and this is the most critical point. Uncontrolled chronic inflammation in VLS leads directly to a significantly increased risk of developing vulvar squamous cell carcinoma.
Cancer.
Yes, cancer.
Wow. So by trying to avoid the smashed window of a potential steroid rebound, they're letting the broken heater of the disease freeze the house entirely.
Yeah.
And in this case, freezing means permanent anatomical destruction and a high risk of vulvar cancer.
Exactly. The stakes could not be higher. The ultrapotent steroids are the primary defense standing between the patient and malignant cellular changes.
That's their shield.
It is. The goal of modern dermatology isn't to run away from steroids out of fear of TSW. The goal is to use them so strategically and so precisely that the rebound effect is never triggered in the first place, while the cancer risk is suppressed as close to zero as humanly possible.
Which means the entire game hinges on the dosing strategy. How do you actually walk this tightrope? Let's dive into mastering the maintenance protocol.
This is the most important part.
What is the evidence-based strategy to keep the immune wrecking ball at bay without causing the blood vessels to become addicted to the steroid?
It all comes down to a strict, disciplined tapering strategy. The British Association of Dermatologists, the BAD, outlines a very clear, highly effective protocol.
Okay, what is it?
Well, the single biggest mistake patients, and sometimes well-meaning primary care providers make, is assuming that an ultra-potent steroid should be used daily forever.
Right.
It absolutely should not. Daily, continuous use is the exact mechanism that causes the receptor downregulation and vascular addiction we discussed.
So what does the safe induction look like?
The BAD regimen typically starts with daily application of the ultrapotent steroid for exactly 1 month. This is the acute induction phase.
Okay, so just 1 month.
Right.
Yeah.
The goal here is to aggressively knock down the active roaring inflammation and halt the architectural damage.
You are bringing the heavy artillery to put out the roaring fire.
Yes, but then, crucially, in the second month, you taper down. You reduce application to every other day.
Ah, so you are slowly easing the foot off the gas pedal, allowing the local tissue to start waking its own receptors back up.
Precisely. You're preventing the tissue from becoming entirely reliant on the drug. And by the third month, you taper down again to the lifelong maintenance dose, which is typically just twice a week.
So it's like switching from a high-pressure fire hose to a slow-drip irrigation system.
Yes?
You put out the massive forest fire in month 1, and for the rest of your life, you just use the sprinklers twice a week to keep the ground damp so the embers can never catch fire again.
That's a perfect visualization. And this twice-weekly protocol is the crucial safety net. Remember, TSW is triggered by the abrupt discontinuation of long-term, continuous daily use.
Right, daily use.
By tapering down to just twice a week, the steroid acts as a low-level background suppressor. It keeps the autoimmune disease in remission, but it never overwhelms the vascular tissue to the point of causing addiction or rebound.
And there is a really fascinating, highly practical metric in the clinical guidelines for you to remember as a listener. It helps patients gauge if they are accidentally creeping into the danger zone of overuse. It's the 30-gram rule.
Oh, this is an incredibly useful self-monitoring tool for patients to understand their exposure.
So to put this in perspective, dermatologists often measure creams in fingertip units, or FTUs.
Right.
A standard 30-gram tube of clobetasol contains a lot of fingertip units. The guidelines state that during the initial intensive 3-month tapering phase, so the daily use, then every other day, then twice a week, a single 30-gram tube should last the patient the entire 3 months.
Correct. Because you are treating a highly localized area, the actual volume of ointment needed per application is very small, usually just half a fingertip unit.
But the real diagnostic clue comes during the maintenance phase. Once a patient is stabilized on that twice-weekly protocol, that exact same 30-gram tube should last a full 6 months.
6 full months, yes.
If a patient looks at their pharmacy records and realizes they are burning through a 30-gram tube of ultra-potent steroid every 6 weeks while supposedly on maintenance, it is a massive red flag.
It strongly implies one of two things. Either their disease is poorly controlled, and they're experiencing breakthrough flares requiring more medication, or they are overusing the ointment.
Just putting on way too much.
Yeah. And that continuous overuse is exactly what risks pushing the tissue toward a TSW rebound.
It's a brilliant, tangible way for a patient to track their own risk. I mean, if you are buying more than 2 tubes a year, you need to talk to your doctor.
Absolutely.
But the guidelines also emphasize that steroids shouldn't be the only tool in the toolbox. There are adjunct therapies heavily recommended alongside the clobetasol, specifically emollients and barrier creams.
Yes. Emollients are a critical component of lifelong VLS management. We're talking about heavy, bland moisturizers designed specifically for sensitive tissue.
Okay, but if the steroid is doing the heavy lifting by suppressing the immune system, what is the mechanical purpose of slathering on a heavy moisturizer? Like, how does that help mitigate the steroid risk?
It comes back to the concept of the skin barrier. VLS inherently damages the skin barrier, making it dry, prone to micro tears, and highly susceptible to environmental irritants like urine or friction.
Right.
Emollients don't replace the steroid. They don't suppress the immune system at all, but they artificially restore and protect that physical barrier.
I see. So the emollients act like physical armor. They seal in moisture and protect the tissue from external friction, which means the steroid doesn't have to fight a two-front war against both the autoimmune disease and environmental irritation.
Exactly. When the barrier is hydrated and physically protected, the tissue is calmer. This allows the topical steroid to act much more efficiently.
Oh.
In many clinical observations, rigorous use of emollients can actually reduce the total amount of steroid a patient needs to reach and maintain remission. And anytime you can achieve remission with a lower total lifetime exposure to steroids, you are further dropping the risk of adverse effects like TSW.
So what does this all mean? Let's bring this all together for you. We started by looking at this terrifying concept of a steroid rebound topical steroid withdrawal.
Right.
And we've seen that it is a very real, incredibly painful vascular and inflammatory crisis. If you overuse ultra-potent steroids continuously and then abruptly stop, your blood vessels dilate wildly, your local immune regulators fail, and your skin can erupt in a fiery, spreading redness.
But the vital takeaway is contextualizing that risk.
Exactly. Because in the specific context of vulvar lichen sclerosus, ultra-potent steroids are not the enemy. Because the disease causes hyperkeratosis, thickening the skin, the steroids don't cause atrophy the way they would elsewhere.
No, they don't.
They are actually the ultimate protectors of the tissue's structural integrity, and they are the primary proven defense against the progression to vulvar squamous cell carcinoma.
The secret is entirely in the taper.
Right. You do not use them daily forever. You use them aggressively to put out the fire, and then you taper down to a lifelong, twice-weekly maintenance routine supported by a robust barrier of emollients.
Exactly.
If you adhere to that protocol, monitored by that 30-gram rule, you secure all the cancer-preventing protection of the steroid while essentially eliminating the risk of a TSW rebound.
It really is a phenomenal testament to how precise modern pharmacological management can be when the mechanisms are fully understood. But as we wrap up, I want to leave you with a final thought to mull over.
I love that. What is it?
Consider the profound psychological resilience required of patients managing chronic conditions like VLS.
It's immense.
It really is. They have to rely on a lifelong medication that carries a stigma and a severe warning label. Every day, they're constantly balancing the fear of the treatment's potential rebound against the devastating certainty of the disease's progression.
That is a heavy burden to carry.
It is. It forces us, in the medical community, to ask a hard question. How can we better design patient education so that empowerment, rather than fear, drives compliance?
That is such a powerful thought to leave on. Thank you to everyone listening for joining us on this deep dive into the medical literature. We hope we've helped decode the science and clear up the diagnostic muddy waters for you today. Until next time, stay insanely curious.